A very good morning to you all. I welcome to our IC, that is Next Gen Retinal Imaging, Transformative OCTA application and AI integration. So thank you for reaching us this early hour in the morning. We are going to discuss various nitty-gritties of OCT angiography, for which we have planned a panel of exemplary speakers. So there would be slightly change in the order of the talk. So for the first talk, I would like to invite Dr. Nikita, and she is going to speak on AI innovations in OCTA, a game changer for ophthalmic imaging. Dr. Nikita is Dr. Nikita is an RPC element. Rajendra Prasad Eye Center is one of the most prestigious eye center of this country. She has completed her MCH in Retina from another exemplary institute, which is PGI Chandigarh. Over to you, Dr. Nikita.
Thank you, sir, for the kind introduction. Good morning, everyone. At the outset, I would like to thank the organizers and Dr. Ankur, sir, for giving me this opportunity. I'll be talking about AI innovations in OCT angiography, which is actually a game changer for ophthalmic imaging. We all know that OCT angiography has revolutionized retinal imaging by providing high-resolution, non-invasive visualization of the retinal and choroidal vasculature. Now, with the integration of artificial intelligence, especially machine learning and deep learning, it's undergoing a transformative leap in diagnostic and analytical capabilities. Let's briefly look at what is machine learning. It's a branch of AI that enables systems to learn from data and improve over time without explicit programming. Its applications in OCT angio include automated segmentation of retinal layers, disease classification, predicting disease progression, enhancing image quality, and quantifying vessel density. Deep learning, however, is a subset of machine learning that uses neural networks with multiple layers, as the name suggests, deep learning, to model complex relationships in data. It can analyze OCT angio scans at a deeper level and identify subtle patterns which are beyond human capability, which include precise vessel segmentation, detection of capillary dropout or neovascularization, image denoising and reconstruction, multimodal image integration, anomaly detection, and predictive modeling. So machine learning works well with less data, requires manual feature selection, has simple algorithms, less computationally intensive, and easier to interpret. However, deep learning requires larger data sets, learns features automatically, involves complex neural networks, requires computation, and is often difficult to interpret. Let's look at the applications of AI in OCT angiography one by one. Now, signal generation is one of the most important tools to generate good OCT images, and we know that it requires multiple B scans to measure motion contrast and extract flow signal. However, learning algorithms can be taught to create OCT-like angiograms directly from maybe a single OCT scan. This transforms the OCTA signal generation from a motion contrast measurement to an image translation problem, which is a well-studied branch of machine learning. So this is an OCT angiography signal generated from a Zeiss angioplex machine, and this is an OCT angiogram generated from a deep learning algorithm using just a single B frame, which is almost similar to what a normal OCT angio scan looks like. So it not only requires shorter OCT angioscan acquisition times, but also induces less motion artifacts. And it can also recover information from currently available clinical OCT scans in which OCTA scan pattern was not applied, potentially increasing the amount of data available for OCT angiography quantification and development. However, sometimes this extracting information from just a single B scan can be challenging, and it has been shown that sometimes AI fails to capture some capillary details which can be obtained from OCT angio. Coming to the next application in OCT angiography reconstruction and enhancement. Rather than generating OCT angiography data from the starts, convolutional neural networks can be applied directly to the already available scans to improve image quality. So one of the major limitations of contemporary OCTA scans is that for a larger field of view, the peripheral data has low image quality. However, this is a reconstructed OCT angio scan from the original scan using deep learning algorithm, and we see the peripheral scan quality is also enhanced, and there is no loss of image quality even in the periphery. So image reconstruction networks offer the potential to improve OCTA angio image quality without inducing any data acquisition problems. Next is retinal slab segmentation. It is a final piece essential to generate on-fast OCT angiograms of each capillary plexus. Now, how do these retinal slab segmentation algorithms work? They usually work by identifying features in the axial reflectance profile and correlating them with anatomic features. However, these are vulnerable to changes in magnitude due to speckle variation, any pathology like retinal fluid drusen, or low image contrast. And therefore, they are not specially robust. Semi-automated procedures can also be done to improve performance, but they're potentially labor-intensive. So with deep learning, models can be optimized to accurately segment retinal slabs for eyes with a specific disease. So this is a retinal slab, peripapillary retinal slab segmentation done using a convolutional neural network. This is through the peripapillary, through the red line, and this is through the blue line, that is through the optic nerve head. And we can see all the layers segmented from the ILM to the RP Brooks complex. Next, most important is artifact removal. AI can also be used to identify and remove specific artifacts. Let's first see the bulk motion artifacts. We know that these manifest as extremely disruptive bright stripes, although they can often be removed through hardware approaches or registration of different priority scans, but their information will still be missing from those scans which are lost to the microcircuits. So instead of replacing these missing frames, the convolutional neural networks utilizing deep learning generate angiographic data for even the microcircuit affected B scans. Any bulk scan due to slower forms of motion like ocular pulsation and drift can also be corrected with these AI algorithms. So this is a original OCT angioscan, and we can see the background is not very clear, and this is the normal OCT angiogram, and this is a regression-based bulk motion subtraction algorithm used OCT angioscan generated through deep learning, and we can see there is much better contrast between the vasculature and the surrounding tissue. Shadow artifacts, as we know, are especially problematic, especially since in severe, they cause signal attenuation, and best is to detect these artifact-affected regions in order to exclude them from quantification, because they can erroneously detect non-perfusion areas. Now, shadowing artifacts indiscriminately darken both the structural OCT as well as the OCTA angiography signal, and this simultaneous occurrence can be used by intelligent algorithms. The random forest is one of the deep learning technique which is capable of accurately segmenting shadow-affected regions. So this is, you see the OCT angiogram detected through the deep learning, which has detected this shadow artifact which is being created because of the vitreous floater in both this patient of uveitis as well as in this patient of diabetic retinopathy, so that this is not erroneously detected as a non-perfusion area. AI can also help in analyzing a lot of OCT angiographic features like vessel density and segmentation. It's a valuable metric which correlates with disease severity, especially in eyes with DR and glaucoma. And it's usually a segmentation task, and CNN algorithms have been shown to perform comparable to manual segmentation. So this is a CNN generated output, which is segmented the vessels using a deep learning model. The differentiating arteries and veins. This has also been shown to be done by CNN algorithms with more than 80% accuracy. So to generate these differentiate between arteries and veins, they register the on-fast OCT images with the color fundus photos and also use the structural OCT information and can help differentiate arteries and veins, because otherwise manually doing this is a very difficult task, because it's not possible to differentiate using the flow signals alone. Non-perfusion areas, we all know that they are very important to identify certain vascular pathologies, and they are very similar to shadowing artifacts. Though they are superficially similar, intelligent combinations of structural OCT and OCT angio data can distinguish these non-perfusion areas and shadowing artifacts. So the deep learning algorithms can again identify these with a more than 95% accuracy, and they're resistant to any image quality artifacts. So this is a non-perfusion area. We can see all these non-perfusion areas has been differentiated by the CNN network from any shadowing artifacts. The yellow ones are the shadowing artifacts and the blue ones are the actual non-perfusion areas, which has been done by a deep learning algorithm. So choroidal neovascular networks are also very important to identify, and projection artifacts, we all know, appear very similar to these choroidal neovascular networks since they retain the vascular characteristics of the vessels that generate them. They can also appear on top of the real CNVs, detrimentally influencing any related quantifications. So deep learning algorithms can perform robustly despite these similar complications with an accuracy of more than 95%. So this is a deep CNVM detection using a deep learning algorithm. They take a raw inner retinal angiogram and a projection resolved outer retinal angiogram and a volumetric structural data from the outer retina as input, and then they generate a CNVM membrane, and then further segmentation can delineate the CNVM vessels alone. Retinal fluid also is more readily identified in structural OCT scans. However, they still have a signature in the OCT angio channel since vessels do not occur in fluid regions. The deep learning algorithms can again identify the retinal fluid. So this is a retinal fluid generated through the deep learning algorithm pre-treatment, and this is post-treatment, and then they can show that where the pre-treatment fluid was there and now where the post-treatment fluid is remaining. So we better know how much fluid has actually resolved, even on the OCT angio scans. So AI in OCT angio improves not only efficiency, but also accuracy. Obviously, it reduces human error, improves diagnostic precision. It improves consistency by uniform grading of scans, increases scalability by handling large volumes of data in real time, and it can early detect a lot of pathologies. However, there are certain challenges and considerations that come with AI, which is, of course, data privacy, bias in training data, interpretability, making AI decisions understandable to clinicians, integration of AI tools with clinical workflows, regulatory handles, and clinician training. So to conclude, AI innovations in OCT angio represent a paradigm shift in ophthalmic imaging, and by leveraging the power of machine and deep learning, clinicians can unlock deeper insights, enabling proactive and personalized patient management. It not only enhances diagnostic speed, accuracy, but also accessibility. It's poised to be essential in future ophthalmic care. So the fusion of AI with OCTA promises a new era of precision diagnostics, early detection, and individualized patient care. What the future might look at real-time diagnosis, predictive analytics, teleophthalmology, and maybe AI-driven research. These are my references. Thank you, everyone.
Thank you, Dr. Nikita. Any questions by anyone?
Thank you, Nikita, for very wonderful insights into how OCTA is being driven by AI now. And I think we already have some amount of, algorithms which as of now fill in data, because we have data gaps when we acquire these scans through various machines. So all commercially available machines do use some kind of algorithms to fill in these kind of data. So one thing I would like to ask you is, are there any projects or going on whereby AI based on OCTA would help us in predicting the future of a human being in terms of developing future diseases, maybe neurovascular disorders like Parkinson's or Alzheimer's?
So I'm sure they may, but I'm not really aware of.
Sir, there has been a study going on recently. Initially, it was a pilot study to compare the vessel diameter and to look at the vessel diameter from the OCT angiography and compare it with neurodegenerative diseases. So they have found a significant correlation in a way that the vessel density, when it decreases, they have seen that these are the patients who are predisposed to Alzheimer's as well as stroke. So this Alzheimer's is a one different study, and stroke one is the second one study. So building upon these AI algorithm, what like the Google did it for diabetic retinopathy. What they are trying to do is that they are trying to have a positive predictive value for a disease, and the future that is gonna unravel is that a one machine which has an fundus camera, OCT angiography, OCT inbuilt into it, is going to diagnose you without the need of a human over there. The same data is going to be shared to the registered retina practitioner who is going to be in the same city or different city, and you will be booked with that. So that's how the paradigm is changing.
I think that's very important, because what is going to happen is probably we will be able to predict the various diseases which a person is predisposed to. And that will be a very useful insight as to which person is predisposed or not in a very non-invasive way. Yeah. So that is one important thing. And as of now, we are all aware that there are many AI algorithms which are available. You can call the next one. And what happens is that there has been none, actually, if you see, everybody is developing AI algorithms, but which has been used commercially. So people have been developing, individual people have been developing, but I don't think they have been put to use, because no one is ready to buy them, who is ready to invest in AI technology to be used in clinical practice. I think that is something which remains a challenge as of now.
Yes.
Thank you, Nikita. So for the next talk, that is going to be on OCT applications in age-related macular degeneration and polypoidal choroidal vasculopathy and beyond, I would like to invite Dr. Bhuvan Chanana. Dr. Bhuvan Chanana is an alum of prestigious RP Center. He is currently working as the Chief of Retina Services at the Center of Excellence in Ophthalmology, the Bharti Eye Hospital. Over to you, sir.
So, I'd like to thank Ankur for giving me this opportunity, and a very good morning to all of you. So, I think as Vinod had also highlighted in the chairperson, Ankur, I think AI will take over everybody in the next 20 years, and we'll probably be sitting at home only. So, I'll just start. I'll be giving a more practical approach. I think OCTA and neovascular AMD is quite a huge topic, so I'll just try to keep it short and its role in PCV and non-exudative macular neovascularization. So, the classification of type 1, type 2, type 3, we all know one is subretinal, one is between the subretinal and above the RPE, and the other is intraretinal. The type 1 is below the RPE. So, sometimes the detailed examination of the microvascular complex is not visible on a FA or ICG, but with OCTA we can get very detailed segmentation of the superficial capillary, the deep capillary, outer retina, choriocapillaries, and it's continuously improving as highlighted in the previous presentation. So, this was one study I did when OCTA just came in 2010, I think 18 or 17 when we had it. So, I just tried to categorize, and I found that 71% patients had a type 1 CNVM, around 20%, 25% had type 2, and type 3 at 5%. So, this is also sometimes important because you know that the type 2 and type 3 CNVMs, they do not require the newer generation anti-VEGFs, and they respond probably very nicely to ranibizumab only, and also not even some cases they lead a very long treatment. So, OCTA has really improved that. So, just showing few pictures of a type 2 CNVM, the OCTA, you can see the well-defined vascular network. I'll just show what we did in this study. This is a RAP lesion or a type 3 CNVM which can be seen in the intraretinal space. So, the main thing on a CNVM, when we see the pattern which I saw, that there was a main central trunk and then it was radiating in all directions from the central trunk, and that is a medusa pattern which we saw in about 57% of the patients, that is 12 eyes, and a C-fan pattern in 5 patterns in which they radiate on one side of the lesion. And around 20% of the patients had an indistinct pattern, and there was lack of any well-defined pattern or distinct vessel pattern. So, these are a few pictures of indistinct vascular pattern which could not be categorized into a medusa or a C-fan. And as I said, a large main central vessel could be seen in 76% of the cases. So, when we treat, we don't have to treat all these membranes. Basically, the large trunk usually remains, and the smaller calcium vessels, they tend to reduce on treatment. And we can also base our treatment with a combination of OCT. Sometimes there are a new spurt of vessels or a AVN which can be seen on an OCTA. So, this is another indistinct pattern which I could see on the outer retina and the choriocapillary layers. There are 2 vascular patterns, but this is not a well-defined pattern. So, as I just stated that the main feeder vessel usually remains the same even after treatment. However, the smaller vessels, they tend to get attenuated or shrink, but and it is a sign if they are increasing that probably the disease activity is increasing and come back and is an indication for treatment. So, this is another thing which we observed, that there is hypoperfusion of the choriocapillaries surrounding the neovascular complex, which could be a reason for the pathogenesis leading to the secretion of the cytokines and VEGF agents that lead to the further proliferation of these membranes. So, this was one hypothesis which was made in a study also, that these areas of hyperperfusion which are present adjacent to the vascular networks are probably the main culprit for the formation of these vascular membranes. So, for AMD, I'll just, as I said, I think it is a very good technique to directly visualize it, to study the neovascular membranes. We can see the microvascular details very clearly, and in 81% of the patients we could identify a well-defined vascular pattern on OCTA. Now, coming to the second part is the pachychoroid. I think this is something which is really come up with a boom in the past 5 years, and we should focus on this because many of these conditions require higher end treatment. We can also treat the extrafoveal polyps with a laser. So, it is a disease spectrum which is categorized by, I think we all know that, by the PPE, CSC, and then neovascularization, and then PCV. So, but for PCV, I'll just highlight further also. I think ICG is still the gold standard because on OCTA it is very difficult to find a polyp unless you know already it is there. Probably retrospectively it's much more easier to find it. So, And these are some classical signs on OCT which give with the 80% around specificity and sensitivity, which will show that probably there is presence of a PCV lesion only. These tall PEDs, thumb PEDs, large PEDs, notched PEDs. So they are usually associated with a polyp which is present at the edge of the PED or at the just underneath the PED. So this is just a comparative. A study was done in which you can see on an ICG there is a polyp which is present, there is a large PD, and the polyp can be seen just underneath the PD. So now we'll just compare this image with the OCTA images. So when we do a OCTA, we can see that on the outer retina slab there is no well-defined membrane, but we can just see the formation like of a half ring. So it's very difficult at that only because I already knew there was a polyp, so I tried to do it. And when we go at the level of the choriocapillaries, then there is an adjacent branch vascular network which is also seen, and the polyp which can be appreciated at the level of the choriocapillaries. So when we did a color composite, so that was the location of the PED where which was identified, and the adjacent double layer splitting sign was corroborating with the choroidal neovascular complex. So these are another examples in which OCTA shows the polyp as in the initial it showed as a semicircle, and here it is showing as a complete circle. The A2 image is a polyp, a well-defined polyp. However, on OCTA we can just see these yellow dye dots which are present along. Why is this? Because the blood flow is usually very slow in a polyp. However, at the edges of the polyp, the blood flow is much more, the velocity of the RV is much faster. So hence it picks up in the form of a complete circle or a half circle. So another, there is a cluster of polyps which can be seen as a hyperfluorescent on ICG. However, when we do OCTA angiography, then we can just see these we can see these white dots which can be seen, which are just a cluster of polyps. So these are also the things which sometimes, if you have this picture, you can probably pick it on an OCTA, but usually having such polyps is very rare. So I just come to the D2. There was another polyp on ICG in which you can see on ICG, but however on OCTA there is no well-defined polyp which can be seen, which can be very easily missed. So so that's why I'm saying ICG is still the gold standard for diagnosis of PCV and for the polyps. However, OCTA maybe in future, I think with the further technology, you will be probably able to pick up polyps much more easy, but however it's very difficult to make a diagnosis of polyps purely on an OCTA. So as I said, the slow velocity of the blood is not captured on the OCTA, and at the periphery of the large polyfoidal lesions, the blood flow is faster, and hence they present as a complete ring or a half ring. And most of the times I feel that it's very difficult to pick up a polyp on an OCTA. So just one patient, you can see I did a PD, there is a large PDs there is a CNVM. So when I did a OCTA, I could just see a branch vascular pattern with a large PED, but no polyp could be appreciated. So when I did a ICG, you can see that there is a well-defined hotspot is there is a hyperfluorescent region which is increasing, and I had a very high suspicions of polyp in these cases, even based on the fundus photograph in the examination, and that is why I did a OCD angiography, and it came out to be a polyp which was missed on a OCTA. Now coming to the third part is MNVs, that is non-exudative MNVs. So as the name suggests, there is no evidence of any macular fluid, and these patients are usually asymptomatic. Fellow eyes usually have an incidence of AMD of around 6% to 30%, and there is a chance of some exudation in these patients which ranges from 20% to 80%. So OCTA is a very good instrument to follow up these patients and to look whether the size of the complex is increasing, combined with the OCT whether there is any fluid. So as long as there is no fluid, there is no need to treat the patient, because one, there is an active lesion, because these are also protective for geographical atrophy. Once the lesion becomes active, that is an indication for the treatment. So OCTA is definitely superior to angiography in these conditions, in which you can see a very well-defined vascular pattern. It is done in a matter of few seconds, and we don't have to do a invasive procedure. So it is in OCT also there is a high suspicion by the double layer splitting sign. You can see that there is presence of the CNVM, but it is not as sensitive as an OCTA. So as I said, this is a case which was which I just took it from a study. So you can see that the vascular complex over a period of 1 year started to increase, and there was oxidation. They treated the patient, and then it got dried, but again the fluid is coming up. So this is the main advantage of doing a OCTA and keeping the patient under follow-up, and also giving him probably a Amsler chart or something to self-monitor. So this was another case which did not worsen even at 24 months. So there was no need for treating this patient. So most of these complexes do not disappear with anti-VEGF treatment, hence we should not treat these lesions. And the goal of the treatment is not to eliminate these non-exudative membranes, but it is to prevent the further exudation if it occurs. And as I said, they also slow down the growth of geographical atrophy, hence there is no need to treat such lesions. So I think multimodal imaging, they have really revolutionized our understanding of AMD as well as PCV, and it shows a very good morphological analysis of occult CNVMs, and as I said, of type 3 CNVMs, and we can even differentiate the treatment. But for PCV, ICG is still the gold standard, and for, as I said, for non-exudative MNV, there is no need to treat before any exudation develops, as it even has a protective role. So I think that ends my presentation. Thank you.
Thank you, Dr. Bhavan. So, an excellent presentation. You being at RP Center, what's your take on the various machines that are available to? Is there any difference in the machines that can give you better results, or is just the same?
I have used almost all images, all machines, including Spectralis HRA, Topcon, that is web sourced, and then Zeiss and Optopol. So OCTA, if you talk in terms of clinical terms, I think they are by and large equal in terms of whether you are able to detect a lesion well or not. All machines will make some amount of errors in terms of segmentations, but that you have to sit on your own and calculate, do the manual, sections to come to a conclusion. And it's very important that we see the corresponding B scans ourselves on the machine with flow signals. So that is something which is very useful. And I think AMD, and especially in the setting of PCV, OCTA has changed how we work up a patient. Earlier we had very low threshold for FA and ICG in these patients. I think nowadays we hardly ever do FA. It has been virtually replaced FFA. OCTA is all, and especially in conditions where you have flat irregular PEDs, which you were never sure on FFA whether you could detect these CNVs or not, but now it's very easy. Some other conditions like Mectel type 2, for example, inflammatory CNVMs. Now these are all conditions where we used to do FFA. It was very difficult to pick up the CNVs, but now we can do that beautifully with OCTA.
Thank you. One question to you, sir. Have you used OCTA images of PCV to direct your focal laser? Because as a management principle, if there is an extra foveal PCV, we are trying to target it with the focal laser. Have you tried it in focusing your laser based on your images of OCTA?
Definitely, but not OCTA. I think ICG I would prefer to do a ICG to locate the polyp before doing a laser. I will not base my treatment on, as I said, for detecting polyps only, OCTA is not a very good instrument. You will miss it in about 90% of the cases unless it is a very large polyp or a cluster of small polyps. So I think we should do a ICG, and if there are extra foveal polyps, probably give an anti-VEGF to reduce the exudation at the fovea, and then go ahead for laser to reduce the further number of injections.
And I like to have the opinion of the panel that when we are lasering for PCV, will you like to target only the polyps or the BNN, the origin of the BNN?
I think usually we target only the polyps. There's no need to target BVN or BNN, what we call, because usually they tend to be very large and can span the whole macular area. So polyp usually which are at the edge of the network, so they tend not to be subfoveal mostly, while BNN is very commonly subfoveal. So we always target polyp, because that is the baseline or base of all the problems we are going to have because of PCV.
Usually the vessels, they will erupt at the edge of the polyp only. These are usually formed. So I think if we treat, as Vinod said, the polyp only, it can also take care of the AVN from any exudation.
Thank you, sir.
So do you laser only the over the polyp or surrounding the polyp also?
I think you should you should laser the polyp directly.
No need of surrounding.
It does not serve the purpose. The idea is to thrombose the polyp. So if you do surrounding to it, it does not work.
Okay.
Thank you.
Thank you.
Thank you, Dr. Bhuvan, once again. For the next talk, I would like to invite Dr. Devesh Kamawat. Dr. Devesh Kamawat is alum of prestigious RP Center AIMS, New Delhi, and he's currently working again at RP Center, and he's going to talk on mastering OCTA interpretation toolkit and addressing the artifact. Over to you.
Good morning, everyone. Thank you, Dr. Ankur, for the introduction. So I'll be talking about the basics of OCT angiography, how do you interpret and how do you take care of the artifacts which are very common in OCT angiography. So OCT angiography, as you all know, is a dialysis angiography in which we acquire and analyze the en-face images of the retinal as well as the choroidal microvasculature in a depth-resolved fashion. That is, you are able to segment the individual vascular layers, the superficial plexus, intermediate, deep plexus, choriocapillaries, and the choroidal stroma. You can segment them in a depth-resolved fashion, and that prevents the overlap of the vascular structures. Unlike in fluorescein angiography, where you are not able to analyze the deeper structures, you are mostly able to analyze the superficial vascular plexus in the retina. Here you can analyze all the layers of the vascular plexus. Now, since there is no dye which is used in OCT angiography, so there is no leakage. So OCT angiography images will be will have very high contrast, and because there is no image, there will be very less obscuration of the underlying vascular details. Another important benefit of OCT angiography is that it doesn't require any dye, doesn't have any side effects, can be done very quickly, and can be repeated in patients those require repeated imaging, unlike fluorescein angiography, which can have its side effects and contraindications and is not routinely done on successive follow-ups. Now, what is the principle of OCT angiography is it's based on the decorrelation signals. What do you mean by that? So in this, there are successive images are taken, B-scan images are taken at a particular point in the retina or the choroid, and what is the signal that is coming from these two images? The detector detects the difference in the signal from these two images at the same place. So there is a decorrelation signal that is detected by the detector, and then this decorrelation signal, the machine interprets that it is occurring because of any movement within the structures which are captured by the B-scan. So since retina, choroid and the eye is not a movable structure, otherwise the internal structures are not moving, so what is moving is the blood. That is the blood flow, it is there, the RBCs are moving. So that decorrelation signal is occurring because of the RBC movement from one place to another in the same B-scan image which is taken at very short intervals. So that gives you a decorrelation signal, and eventually the machine creates a decorrelation map which shows you the flow of blood. It's not the vessels, it is the flow of blood which is shown here. That is the blood column that is moving, the RBCs which are moving. So it is not the vessel wall which is seen here, it is the vessel blood flow which is seen within the vessels. Now, inter-scan time is very important in OCT angiography. So basically you are taking successive B-scan images which are separated by a very short inter-scan time. Now, if the if the blood flow is very rapid, so the RBCs will move out of that B-scan image very quickly unless you have very short interspan time. You need to have very short interspan time so that successive B-scan images are taken when the RBC is moving from the first red dot to the second red dot. But then the RBC should not move out of this B-scan image also. Otherwise, the flow will not be detected. So very short interscan time is required for higher blood flows. Higher blood flows require very short interscan time, and very low blood flows, if there are very low blood flow, suppose in a microaneurysm or in a polyp, then you need to increase the interscan time, because the RBC movement from one place to another will take a lot of time when the blood flow is slow, and therefore your successive B-scan images should be separated by a longer interscan time. So what is the problem? You can increase the interscan time to a very long but then there comes the eye motion and artifacts arising because of that. If you increase the interscan time, the total scanning time will increase and the eye movements are going to happen, and that will lead to motion artifacts. So that's why most of the machines do not allow you to change the interscan time, and they have a preset interscan time that allows minimum artifacts and maximum flow that could be captured. Now, there are two parameters that could be detected by the detector. One is the amplitude decorrelation, that is the amplitude difference in the light that is coming from the two successive B-scan images at a single place, or it could be the phase difference. So it could be either amplitude difference or phase difference that is captured by the machine. Now signal is basically the flow that you are seeing, and noise is anything that is interrupting. It could be a cataract or a media opacity or poor tear film, or it could be a poor image acquisition that could be there. So there are certain methods to improve this signal noise ratio, and these are the various methods: split spectrum, speckle variance, and volume averaging. You might come across these fancy names, but what they do is that they increase the signal to noise ratio. Now there are different commercially available platforms which are there. I have no financial interest, but the common ones are mentioned over here: AngioView by OptoView, then Angioplex by Zeiss, Spectralis by Heidelberg, AngioScan by Nidec, and SSOCT Angio by Topcon. Now SSOCT is the last one. The Topcon is the swapped source based, and the rest are the SDOCT based. Now all of these platforms will have their own default layer segmentation. So you cannot compare the images which are taken on different machines of the same patient. You cannot compare them. These machines have different resolutions, different scan areas, and different default layer segmentation. Now, as I told, majority of them are the spectral domain OCTs, in which you have a wavelength of 840 nanometer superluminescent diode is used as the source of light, whereas in swept source OCT based machines, you have a tunable swept source laser which is there with a wavelength of 1050 nanometers. So what is the difference between the swept source and the spectral domain OCT angiography machines is that because of the longer wavelength, your choroid gets imaged better, but the resolution more or less is the same, and the swept source machines have a faster A-scan acquisition. So more A-scans are being acquired in a given time. So the resolution of the images, that's why it could be better. Or you can image a larger area in the same given time also. Now scan size, as I told, so on the left you have a 3 mm scan size, and the right you have a 6 mm scan size. So scan size affects the resolution of the images that you get on OCT angiography. In the left, if you see a 3 mm scan, in the same time you have more time to achieve a higher resolution. More A scans could be done in the 3 into 3 mm scan, and while in the 6 into 6 mm scan, the A scan values are less, so the resolution will be a little less. Now, how do you interpret an OCT angiography when you have an image which is there on the machine? Now you have to interpret it. So you don't only look at the different NFAS OCT images, there are different slabs that could be there. Commonly you have the superficial vascular plexus, then the deep vascular plexus, then you have the avascular zone, and then you have the choriocapillaris. Now here in this image you have a full retinal scan wherein the superficial and the deep and the outer retina, they have been clubbed together. Then the second image is the superficial and the deep have been clubbed together, and then the second image is of the outer retina, and the third image is of the choriocapillaris. Now you not only look at the NFAS OCT images, you also look, as Dr. Vinod had told, that you also look at the B-scan images in conjunction with the OCT angiography images, because you need to have a look at the segmentation, whether it is done properly in these images, and also at the flow signals. So you have down in the bottom, you can see that there is some flow which is seen below the RP level, and then you see in the choriocapillaris slab there is a network of vessel. So now you have more confidence that yes, it's an abnormal network which is there, which has a flow on B-scan image, and the B-scan image is also taken from the right area. Now you also need to look at the structural NFAS intensity image, because I'll come to that later on, but you need to have a look at the intensity, whether the image has been properly acquired or not, whether there are any artifacts which are coming in it, whether there are shadow artifacts which are being misinterpreted as flow void areas. So that is why you need to have a look at all three images: OCT angiography, NFAS images, B-scan with flow overlay, as well as segmentation lines, and the intensity image. Now, Broadly speaking, the utilization of OCT angiography, it lies in detection of the macular neovascularization and characterization of that. And then you have the capillary non-perfusion or the flow void areas that you want to assess. So this is the qualitative assessment, and then in proliferative retinopathies, you can have you can use OCT angiography as an alternative to fluorescein angiography for assessment of early neovascularizations. And last, which is an important benefit over fluorescein angiography, is that you can perform a quantitative assessment of the vasculature as well. Now, important here is that you need to know the artifacts which could occur with OCT angiography, and you need to interpret accordingly and take care of all these artifacts before you come to a conclusion. So motion artifacts are very common, and they happen because of the gross eye motion that happens during the scan. So there are ways by which the machine compensate for it. So one of them is the eye tracker, that the machine stops the scan when there is an eye movement and then resumes it when the eye achieves its normal position. And then machine can rescan the affected area. So the affected area could be rescanned again, and then it could be incorporated in the original image. Another important software correction is also there in the recent machines, in which you have the machine acquires horizontal as well as vertical raster scans, and then it see how much is the displacement of the image occurring in the successive phase, and then it corrects for that displacement based on these vertical and horizontal raster scans. Next, projection artifact is very important because it will lead you to make an erroneous diagnosis of an abnormal vasculature in the deeper slabs. So it is also known as decorrelation tails. And why does it occur is because the light which is reaching the deeper levels, it is coming after passing through the superficial plexuses, and therefore the superficial networks will have an effect on the deeper slabs. So how do you take care of it? And prior to that, so most of these projection artifacts will be seen at surfaces where there is a lot of reflectivity of the light. So RP being a very reflective area, reflective layer, so most of the artifacts which are seen, projection artifacts, are seen at the level of RP or the choriocapillaries. Now, how do you take care of the projection artifacts? So traditionally the machines used to have slab subtraction. That means the slab, which is, if you see there is a projection artifact in this image, you have the superficial vessels which are network which is projected in the choriocapillaries. You don't expect this network in the choriocapillaries. You have a abnormal vascularization, but this network is projected from the superficial network. So either you can subtract the superficial network from the from the choriocapillary slab, and that will give you only the macular neovascularization, but that reduces the signal intensity of the image. So what is more commonly done is a projection artifact removal software that is incorporated in majority of the machines, in which you see here, this is the superficial plexus which is seen, and then you have the deep plexus in which the superficial plexus has been projected. Now this imaging has been done without the projection artifact removal software on, but when you turn the software on, there is an option in majority of the machines where you can switch on the projection artifact software, and then you can see here that on the left you have a projection artifact removed deep capillary plexus, on the right you have a deep capillary plexus where the projection artifact from the superficial plexus is there. Next is the segmentation artifact. It's very important that you know how to what the segmentation of the machine is, because the machines will automatically segment based on the parameters that it considers from the healthy individuals. But when there is a distortion in the retinal anatomy, the same segmentation parameters or landmarks will not apply to the diseased eye. So if you see in this image, there is some abnormality, there is a neovascularization which is there in the choriocapillaries in the sub-RP level, but because of the bump, if you see the green lines which are of the, which denotes the slab of the deep plexus, you see that is going above this hump, going through the hump, and adjacent, as the yellow area shows, it is going in the pre-retinal area. So because of that pre-retinal area, you're getting a flow void in the middle picture over here. This is the flow void that is happening because of the slab going anterior to the retina. And in the area of the neovascularization, the slab is going posteriorly into the neovascularization, and therefore some abnormality is coming in the deep plexus, but that doesn't mean that there is some neovascularization within the retina in the deep plexus. It is actually in the choriocapillaries beneath the beneath the RP. So you can manually, actually the segmentation should be along the pink lines that are shown, but the machine is not able to do that because of the distorted anatomy. And so you can manually change the segmentation, the inner and the outer layers, and then look for the abnormality appropriately. Now shadow artifacts, as I told, it's the last artifact that in this image you can misinterpret it as a flow void, but when you see the signal intensity, you know that the signal is already lost. So in the B scan image, you see there is a lot of edema. That's why the signals are lost, and it's not the flow void. And another example in which you see that there are different flow voids which are seen in the choriocapillary slab, but when you see the fundus image and the OCT image, you know that there are a lot of drusens which are there, and therefore it's a shadow artifact which is occurring. Now, OCTA quantification, briefly about it, that you have the option of measuring the vessel density and perfusion density, which are available within the most of the machines nowadays. Vessel density is the length of the perfused vasculature per unit area, whereas perfusion density is the area of perfused vasculature per unit area. And you can quantify this according to different zones in the grid. Then you have an option of measuring the FAS, that is foveal avascular zone. You can measure the diameter, the circularity index. These are also available in majority of the machines. You can use these images to manually threshold them using ImageJ softwares, or you can use other software such as Octava and AngioTool as well. Now coming to the last slide, conclusion. There are certain limitations of angiography, that is the field of view is often limited. There are artifacts, commonly projection artifacts can lead to false impression of the vasculature, and vascular structures which have very low flow such as microaneurysm polyps, they are not very imaged well because they need a very long interscan time, and that is not possible. And you cannot fully differentiate between a leaky abnormal vessel, active leaky abnormal vessel, and a non-leaky anomalous vessel, other than certain characteristic appearance such as a dead tree or a medusa head, but you cannot definitely tell whether they are leaky or not, unlike in fluorescein angiography. And also in inflammatory disorders, you cannot tell about the vascular leakage, which is of very importance in uveitis. And last, you cannot comment on the transit time, which is again important in vascular occlusions. Thank you.
Thank you, Dr. Devesh. Excellent presentation. I'll just like to ask you that at RP Center, you have got access to almost all kind of machines. So which one will you say gives the segmentation error the most, and which one you feel has the least amount of segmentation errors?
No, as Dr. Vinod had already told, segmentation errors will occur in all, and you need to sit down and manually segment them. So I have not noticed any difference in the segmentation errors that occur with a particular machine, but I would like to have the opinion of the panelists as well, other panelists.
Yeah, I think it will happen with all. It's important, and they will happen more when you have abnormal anatomy. So normal retina, they all will do a good job, but once you have abnormal retinal architecture, all of them will make mistakes, and that is where the role of clinician comes in.
Wonderful.
Thank you, Dr. Devesh. For the next talk, I would like to invite Professor Vinod Kumar, sir. Sir is currently working at the prestigious RP Center. He is well-awarded researcher and a great medical teacher. Sir is going to talk about the clinical insights of OCTA in diabetic retinopathy and retinal vascular pathologies. Over to you, sir.
Good morning. So I'll be talking about OCTA in vascular pathologies, and mainly I'll talk about diabetic retinopathy. At the outset, I'd like to thank Ankur for having me in this course. We know that when we assess diabetic retinopathy, we have certain standards of care, and we very commonly use OCT, we use commonly fundus photography, and gold standard is fluorescein angiography, which has been there for long. Of late, I think for past decade or so, we have been using ultra-wide field imaging, and I think again it has changed the way we look at diabetic retinopathy, because while it was considered a predominantly mid-peripheral disease. Now with now with ultra-wide field angiography, we know that diabetic retinopathy is not limited to posterior pole, and it can extend to the periphery of the retina as well. Now, rather than talking just from the literature, what I would like to share you with is the study we did at our center some times back. It was thesis work of one of our candidates, Dr. Nawajish. She is now faculty with us. So what this study planned to do was compare diabetic retinopathy changes as we see them on fundus fluorescein angiography versus what we see on OCT angiography. And we also tried to see if there were any differences on OCTA between eyes who had diabetic retinopathy clinically and the eyes which did not have. So this study was conducted at RP Center. It was a cross-sectional study, and we performed this study after obtaining an ethical clearance from the ethics committee of the AIMS. We had 3 study groups. The group 1 had 30 diabetic patients without any diabetic retinopathy. Group 2 had eyes with non-proliferative diabetic retinopathy, and these eyes may have diabetic macular edema or not. And group 3 had diabetic patients who had proliferative diabetic retinopathy. So this is how essentially workflow of the study was. The eyes where we had no diabetic retinopathy underwent fundus photograph, spectral domain OCT, and these eyes also underwent OCT angiography. However, we did not do any fundus fluorescein angiography in these eyes because we thought it was not required. Eyes with NPDR were divided into 2 subgroups, while the eyes where there was no diabetic macular edema underwent again the same set of investigation, that is fundus photograph, OCT and OCTA. Eyes with DME underwent additional FFA as well. On the other hand, the subgroup with PDR, all eyes underwent fundus photograph, OCT, OCTA and FFA. So what we did is we compared what was seen on FA versus OCTA, and there was a little difference here because the FFA was done considering using standard cameras, while OCTA was done using 8 into 8 mm OCTA scans. Now Zeiss Angioplex was the machine which was used. It gives us 3x3, 6x6 and 8x8, and for this study we used 8x8 OCTA images. And what we assessed was various changes of diabetic retinopathy in terms of microaneurysms, size of FAZ, capillary non-perfusion areas, leakage, irmas and neovascularization. So as I said, these are the various things we assessed, and I'll show you how we fared, how OCTA fared compared to FFA in these eyes. So first, talking about microaneurysms, almost all OCTA scans showed microaneurysms where they were visible clinically, but one predominant difference was when you do a color fundus photograph, you see some amount of microaneurysms. When you do FFA, you see many more, but that is not true with OCTA. On OCTA, you see much less number of microaneurysms, and that is why we know that while CP color photograph underestimates the number of microaneurysms, OCTA also underestimates the number of microaneurysms. Now FFA being the gold standard detects most number of microaneurysms. So this is a patient with, you can see, moderate NPDR. There are some hard exudates and microaneurysms which are visible, but when you go on to do OCTA and FFA, you can see on FFA many microaneurysms are seen, while the same are not seen on OCTA scans. So just highlighting the fact that the number of microaneurysms which you see on FFA are more than what you see on clinical, and what you see on OCTA are much less in number. So another patient, you can see many microaneurysms are visible on the corresponding FFA scans, but if you see the OCTA scans, the much lesser number of microaneurysms are seen. So what was very different in this particular study is that even in eyes where there was no clinical diabetic retinopathy, we found that OCTA could detect some amount of microaneurysms. So this is a patient, you can see there is hardly any diabetic retinopathy which is visible on clinical photographs, but when we went on to do OCTA in these eyes, you can see there are distinctly visible microaneurysms which are there, and thus signifying that what you can see on OCTA may not be visible on fundus fluorescein angiography. Now traditionally we have not been doing FFA when there is no clinical diabetic retinopathy. If we do fluorescein angiography in these eyes, we might be able to detect these microaneurysms. Next was FAZ. FAZ shape and size we all know can be calculated on OCTA scans. One important difference compared to FA is that when you do FFA, there is leakage of dye, and that will lead to fuzzy borders of FAZ, and you may not be able to accurately calculate the size of FAZ. But on OCTA, we found that in all the patients we could accurately detect the size of the FAZ, and these are the various values we obtained. As Devesh highlighted, the various quantitative parameters we saw was vascular density and perfusion density, and we saw that as the grade of diabetic retinopathy increased, all these quantitative parameters decreased, signifying that there is some amount of change even when the size of the FAZ is normal. Now what was very important here is that what we could see is something called posterior or parafoveal CNPs. Now this is a patient, if you see there is minimal diabetic retinopathy, few microaneurysms, but if you see there are capillary dropout areas which are there close to the fovea. Now these have been studied extensively, and people have found out that whenever you have these posterior capillary non-perfusion areas, these signify that the patient is likely to have high risk of progression to meaningful clinical diabetic retinopathy. So then is coming to leakage, and as Devesh highlighted, leakage can only be assessed on fluorescein angiography. Peripheral CNPs, yes, they can be seen on OCTA, but the limiting factor as of now is that we cannot do wide field OCTAs. So what the view we can get on FFA, you cannot get on peripheral on the OCTA. So it is the most important drawback, and I personally feel as the technology evolves, as we'll be able to image the peripheral retina with OCTA, this deficiency of OCTA would be resolved. So this is a patient, you can see there are many CNPs, and when you go on to do wide field OCTA in these eyes, you can very well see neovascularization as well. So with currently available OCTA machines, since we just image the posterior pole, not all peripheral NVs can be picked up, but when you have wide field OCTA which is reaching up to the mid-periphery, you can pick up these neovascularizations very, very well. So this is a patient, you can see there is a neovascularization. So when you do the segmentation at the vitreous level, you can see that this neovascularization is in the vitreous cavity, signifying that this is a raised NV. So to summarize, we found that there is quantitative decrease in the vascular density and perfusion density in superficial plexus as the severity of the disease increases. Also the size of the FAZ increases, which we know already. OCTA can help us in the detection of microaneurysms even in patients where there is no clinical diabetic retinopathy. We have certain patients where posterior CNP areas can be detected on OCTA, and they are better visualized on OCTA, and it signifies high risk of progression in patients with diabetic retinopathy. And as is known, again, increase in FAZ area, distortion and macular ischemia is better visualized on OCTA as compared to FFA. And remember, when you assess FAZ in these patients, it's always best to assess FAZ in deep capillary plexus and not superficial capillary plexus. So as of now, FA remains gold standard for assessing patients with non-proliferative diabetic retinopathy. Because FA is a dynamic process, one added asset of OCTA is leakage, and as of now, FFA provides wider field, allowing us to pick peripheral CNPs and peripheral neovascularizations. OCTA is a very useful non-invasive tool. It shows some changes even in eyes where there's no clinical diabetic retinopathy. It can be used to monitor progression in patients with diabetic retinopathy and is very useful indicator of macular ischemia. Thank you very much.
Thank you so much, sir. Excellent talk as always. I'd like to ask you something about the characteristics of neovascularization over the disc on OCTA. Just by looking at the OCTA image of a NVD, can you say that it is an active NVD or a regressing NVD which has already formed collaterals?
I think it's just based on the size. There's no definitive way to say, because if you do OCTA through various, fibrovascular proliferations where they are all fibrous, even then you will see some vessels which are remaining, as we see in choroidal neovascularizations also. So when it comes to NVD, if you see many small vessels which are running randomly haywire in all the direction, it is likely that this NVD is active. But if you have large vessels which do not have predominant branching patterns, so you can assume that this is healed or resolved NVD. But again, I think you cannot undermine the importance of leakage here. That is a very important feature which you see on FFA.
Thank you, sir. So just one more query in diabetic retinopathy, the utility of OCTA. As now the OCT angio devices are becoming cheaper and they are more readily available, more number of companies bringing in OCTA. How in your practice, what do you advise any patient who comes with diabetic retinopathy, one, any patient who comes with diabetes mellitus, two, any patient that comes with PDR or or without CSME, do you advise OCTA in patients all? Do you want the patient to be assessed because it's a non-invasive? Any patient who comes with diabetic retinopathy may not have an CSME or the clinical diabetic retinopathy per se. Would you ask the patient to undergo OCTA, or do you plan it to do in a certain set of patients, or you plan to do FFA as a baseline and then follow up on the OCTA? So what is your practice?
So I'm, to be honest, I'm still follow old school. So because neovascularization and the peripheral retina is something which we really can't assess with OCTA as of now. So I still do ultra wide field fluorescein angiograms in all my patients with clinically meaningful diabetic retinopathy which needs treatment. So this allows me to document the disease process, and I do OCTA usually at baseline only in patients who cannot undergo FFA. So eyes with deranged KFTs, the patients with deranged KFTs, the pregnant patients. So wherever the patient is not fit enough to undergo FFA, thereby I perform OCTA, and usually we ask our technicians to take montage images of OCTA so that at least till the mid periphery we are able to see. I think with the onset of anti-VEGF therapy for macular edema, we are not that concerned with macular ischemia nowadays. We nowadays do not pay that much of attention to FAZ, which we used to pay earlier when the anti-VEGFs were not there.
So would you recommend doing OCTA in mild or no DR cases and then look at these parafoveal CNP and then maybe change the follow protocol?
Yes, clinically it makes sense, but as I mentioned, even if eyes with no DR progress, they are first going to progress to mild NPDR only. So as of now, since we do not have any treatment for mild to moderate NPDRs where there is no macular edema, so it may not be clinically relevant, but as the time progresses, I think in coming decades, when we have treatment for diabetic retinopathy in mild and moderate, there might be some usage.
Maybe just predicting who will go into meaningful DR.
Yes, definitely, definitely.
Any questions? Thank you, sir. Thank you for enriching us with such a detailed talk on diabetic retinopathy and OCTA. For the next talk, I would like to invite Colonel Pradeep. Dr. Colonel Pradeep is currently working at the most decorated Army Hospital Ophthalmic Center of Delhi, that is Research and Referral Hospital. He's going to talk about exploring wide field OCTA insight into macular telangiectasia. Over to you, Dr. Pradeep.
Good morning, everyone, and thank you so much for attending our IC. First of all, I'd like to thank AIOS and Ankur. Yeah, first of all, I'd like to thank AIOS and Ankur for giving me the opportunity to present today. So, talking about wide field OCTA. Sorry. So, the two images that you see here, one on the right hand side and one on the left hand side, is a 8 mm and 8 mm scan compared to a 12 mm by 12 mm scan. And today we are not limited to 12 mm scan, we are talking about 18 mm scans. And in the trade section, if you had gone to the Intellite podium, they have something called Dream OCT, which is now capable of taking 24 mm scans too. So we have moved from wide field OCTA to ultra wide field OCTA. So the technology has made it possible. So continuing the discussion which Professor Vinod had made. So initial attempts in retinal vein occlusion imaging with OCTA were made with enhanced field imaging. So what the researchers were doing were placing another lens in front of the spectralis machine and increasing the field of focus from 6 into 6 millimeter to 8 into 8 millimeter. And based on their findings, they were able to chalk out the CNP areas in BRVOs and were thinking of advising therapies for the same. By 2020, the research had developed to an extent that we were able to identify neovascularization elsewhere in cases of BRVO and even document them as either CFN type or a nodular type as seen in these cases. But what becomes of this research? By 2022, we had started talking about monitoring the progress of patient using periarterial capillary free zone improvement. And as you see in these consecutive images, we are talking about the normalization of the periarterial flow zone and continuation or discontinuation of anti-VEGF therapy based on OCTA images. Now, based on the wide field OCTA images today, we are able to assess that in such a case where you have a central macular edema but very few CNP areas in periphery, you will give it a chance to develop collaterals and wait. While in a case like this, where even though the macula may appear normal but you have a large CNP areas in the periphery, we will not wait as was recommended long time back in the CVOS and BVS studies and go ahead and do targeted laser photocoagulation to reduce the genesis of VEGF in these cases. OCTA has also found its use in other systemic diseases, and in a case of uremia, when you see multiple cotton wool spots at the posterior pole, initially the thought process was that it was a disease limited to the posterior periphery, but now once you have a wide field OCTA image with you, you realize that the periphery appears quiet because there is no blood flowing through that area, and it is manifest only at the posterior pole because the OCTA shows exactly where the blood is flowing. Similarly, we have been identifying neovascularization elsewhere in such cases, directing our therapy to the CNP areas, and in cases of retinal vasculitis, in one such case of tubercular retinal vasculitis, where we realize that now the disease activity is progressing toward the macula, it becomes clinically a sight-threatening disease, and the immunosuppression in such cases can be escalated from routine steroids to immunosuppressants and probably biologicals like adalimumab. Now, talking about the research which has occurred in newer areas like myopes. So, as early as 2022, people started documenting retinal vessel density in myopes. You will think that what is the usage of such a technology? Now, we have started documenting that in high myopes, to document glaucoma, you can use an OCTA. So, an RNFL defect in a myope can be better picked up on the OCTA image compared to the red-free image as was shown in this study. And these RNFL defects, better appreciated in myopes, give us more tangibility in making a diagnosis of glaucoma and treating these patients, where looking only at the optic disc, it would have been difficult to make that diagnosis because the beta zone is not very evident. So we have found usage for OCTA also in glaucoma. Now coming to diseases like SLE, it has been possible to identify disease activity in cases of SLE where the cotton wool spots have been corroborated with deep capillary plexus flow void areas, as shown in this image with the red dots, and also in finding out whether the disease has halted or is continuing with the development of new CNP areas. And if you find that in an SLE case you are having a propensity to develop new CNP areas over progressive OCTA, one can escalate the immunosuppressive treatment. There has also been research in field of CSCR where choriocapillaris flow has been studied, and we have found that in the central subfield and in the nasal subfield, when you have flow void areas in choriocapillaris, they tend to have a longer duration and active CSCR compared to normal. What these research will have an impact on the treatment of CSCR remains to be seen. Similarly, OCTA angiography has been studied in arterial occlusions where there is an inverse correlation between the retinal thickness and superficial capillary vexillary density with the final visual outcome. For research sake, OCTA was studied in cases of XLRS where they have given out these beautiful void flow areas in deep capillary plexus. They help us in finding out the staging and the progression of the disease, but again the impact on management of XLRS based on OCTA angiography remains to be seen. Now in advanced XLRS they have given these beautiful images also where they show that if the separation of the inner and the outer retinal layer has progressed towards the periphery, it can be better mapped out on an in-face image of OCT angiography. The frontiers have been reached even in uveitis, where we have been able to develop classification systems for Vogt-Koyanagi-Harada based on OCT angiography images and presence of flow void areas in the choriocapillaris segment or the deep capillary plexus segment tend to correlate with active disease compared to a convalescent disease where the earliest sign is the disappearance of these flow void areas in the choriocapillaris segment. Now coming to the second part of my talk, that is macular telangiectasia type 2. As we all know, these are perifoveal grayish areas which appear more temporally than nasally. They have a stage progression over 10 to 15 years, and what one must learn to find out is to look for these discrete white discolorations in the temporal part of the macula to pick up the disease early. Now this is what initially was our understanding of MACTEL, that we used to look at the fundus fluorescein angiography and wait for these fine hyperfluorescences to occur in the perifoveal region. But this was a slightly late way of picking up the disease. The books talk about looking for a right angle dipping vessel, but I will share this insight that in a busy OPD, it is pretty difficult to look for such a case if you are dealing with 100 to 150 patients a day. So one should look for multimodal imaging, and autofluorescence, OCT and OCTA come to our rescue. By 2020 in MACTEL Project 8 report, they had been able to give a classification for various stages of MACTEL and the associated complications that were occurring. But by 2022, there was introduction of OCTA into the classification system, and this was the recent classification system which has been upgraded, and there has been an inclusion of OCTA characteristics, mainly firstly the splaying of vessels in the superficial capillary plexus area and presence of flow void areas in the deep capillary plexus and the presence of telangiectasias in the perifoveal region. So this is the classical progression of the disease, where in image A, you see development of few temporal splaying areas in the deep capillary plexus, which tend to become completely perifoveal, and by the late stage you start seeing development of telangiectasias even in the superficial capillary plexus. So the deep capillary plexus changes also move together with the superficial capillary plexus changes, where in the early stages, though the DCP looks quite normal, but you see development of telangiectasias first in the DCP in image H, and then they progress to a complete disruption of the deep capillary plexus as the disease progresses with fibrosis and development of pigments. This is another example where we can see that there is a complete disruption of the deep capillary plexus as the disease progresses, and in image E you can see multiple telangiectasias present on the temporal part of this fovea. The mactile can be present with concurrent retinal disease, and that is where the importance of OCT angiography kicks in. So in case of diabetic macular edema, if you are having a concurrent macular telangiectasia, even after multiple sessions of anti-VEGF or steroids, you will still continue to find cavitation areas and may unnecessarily treat them. But if you had an access to OCT angiography and you notice a temporal splaying of vessels on SCP, or the presence of these fine telangiectatic vessels on deep capillary plexus, you can make a diagnosis of MACTEL-2 and stop treating this disease. Mind you, MACTEL-2 is more common in diabetics and it is more frequent than we usually document. Similarly, choroidal neovascularization can develop in macular telangiectasia. We have seen cases on record where a MACTEL has been erroneously labeled as a PCV and been treated for almost 2 years with 20 odd injections. And on the other hand, in such a case where a follow-up case of macular telangiectasia developed a CNV, was treated with anti-VEGFs and the disease remained stable for about 2.5 years as reported. Also, if you have a full thickness macular hole with degenerative changes, one should do an OCT angiography to document that this is a neurodegenerative disease and the patient will have a poorer outcome after surgery. There can be other masqueraders with MACTEL, if I may continue for a minute or so. So there can be one with multiple PEDs, and when you do fluorescein angiography or ICGA, the fluorescence from your PEDs will overlie the presence of these fine perifoveal leaks. But in an OCT angiography image, it will be more easy to pick up the presence of concurrent macular telangiectasia. So one has to be on a lookout for this disease in macula. Only then your skill in picking up MACTEL will increase. Similarly, we reported this case of central serous chorioretinopathy and macular telangiectasia. And skipping to the important part, I will show you one of our follow-ups, how we are following up cases of MACTEL on OCTA and how it changes our management. So this lady presented to us as early in 2022, had changes of MACTEL clinically. We started recording the OCT angiography and were managing this case. In 2023, late 2023, we started noticing 2 hyperreflective signals in the deep capillary plexus and couple of hyperreflective signals in the avascular zone. We still did not believe that the patient had development of MNV, though the patient did complain of increasing metamorphopsia. 3 months after that, you are able to pick up these high hyperreflective signals in the avascular zone, metamorphopsia is increased, and these patients do respond to anti-VEGF therapy. So I will conclude that keep hunting for macular telangiectasias in your OCT angiography images. It will save you a lot of pain in post-operative cases of cataract, in cases of DME when you are treating a concurrent MACTEL, and in cases of CSC where a MACTEL might be hidden. Thank you so much.
Thank you, Dr. Pradeep, for the excellent talk and excellent cases that you had shown. In in the paucity of time, I would like to move to the next talk by Dr. Ankur Singh, who is the chief instructor of this course, and he is working as an associate professor at UCMS Medical College, GTB Hospital in Delhi. So he'll be talking on posterior uveitis enhancing diagnostic accuracy with OCT angiography.
A very good morning, everyone. So, I'm going to talk on posterior uveitis, enhancing the diagnostic accuracy of OCT angio. So, as we are aware from the previous talk, OCT angiography has already proven its mettle in diagnosing macular and retinal pathologies. How far the diagnostic utility of OCT angiography in posterior uveitis has been there, and what are the recent utilities, what I'm going to talk about. So FFA and ICG has already been a gold standard in the diagnosis of and management of posterior uveitis. Dual FFA and ICG gives a global information about the structural alteration of the central as well as peripheral fundus. It's a dynamic invasive test, as we are all aware of. It shows leak unlike OCTA. So it can show the vasculitis very well. It works okay with patients with mild vitritis. It has global consensus on the nomenclature, and it is a well-researched tool and has been used by clinicians for over 20 years. On the other hand side, we have OCT angiography, has been discussed by Dr. Devesh. That's a fast, nascent, dye-free, non-invasive technique to visualize and assess retinal and choroidal vasculature abnormalities. It provides us with the structural, perfusion, and vascular flow abnormalities. So unlike FFA and ICG that treats retina as a single layer, it can detect blood flow abnormalities in superficial, intermediate, deep retinal capillary plexus as well as in choriocapillaries. So there are the OCT angiography has been described in various retina uveitic pathologies, but in the paucity of the time, I'm just going to touch upon the important ones. One such would be white dot syndrome. So this is a patient of acute posterior multifocal placoid pigment epitheliopathy. What you see them as clinically is these whitish, yellowish placoid lesion. You do an OCT in these patients, you see those outer retinal hyperreflectivity with the affection of the AIOS junction, secondary to the capillary ischemia. You do an FFA in this patient, you do see hypofluorescence lesions which become hyperfluorescent due to staining, and in ICG you see them on as an hyposenescent, which remain hyposenescent in the later stage. On OCT angiography, you see them as these flow void areas. So how does it help you to differentiate based on the OCT angiography from the other white dot lesions? So another white dot lesion is multiple evanescent white dot lesion, which again looks like these pinpoint white lesions, which are seen on OCT as an outer segment loss, photoreceptor segment loss. You do an ICG in this patient, again you see these flow void areas, so you see these hyposenescent areas. But when you do an OCT angiography in these patients, you don't see any flow void areas in the choriocapillary plane of OCT angio. And this is where the utility, or this is where the limitation of the OCT angiography helps you to cleanse the diagnosis. So OCT angiography cannot detect blood flow in smaller capillaries. So although there is a choriocapillaritis present in multiple evanescent white dot syndrome, there is no flow void areas on OCT angiography. So it helps you to differentiate between this white dot syndrome. So as we are aware that multifocal choroiditis is 1/3 of these patients are associated with CNVM complex. So again, if you see these whitish lesions, you do an OCT and OCT angio, and one of the few lesions you see a CNVM complex, which is very well delineated by the OCT angiography. Probably you're looking at a patient of multifocal choroiditis. Again, one thing which is very common in tubercular granulomas is the RAP lesions. And if you see these abnormal flow in the various NFAS images from top down to the up, from the top up to the down, as well as the flow in the retina, the flow overlay in the retina, probably you are looking at a RAP lesion. So although VKH is something which is a granulomatous disorder, which can be diagnosed clinically and has been very extensively diagnosed on FFA and ICG, so what the study shows, the study that was done in PGI when I was there, that showed that 94% of the patient who had granulomas on ICG were able to detect it by an OCTA. And what is the benefit of it? First, it is non-invasive. You detect those lesions as the flowoid area, as you can see in the left middle picture. You start the patient on the treatment, and these flowoid areas resolve. So once these flowoid area resolve, this will help you to guide the end of the treatment for VKH. So this is another utility of OCTA using the choriocapillaries images. So now this is a patient of retinal choroiditis, and you do an OCT, you see those hyperreflective various deformation in all the layers with ERM present. You do an OCT angiography in these patients, you tend to see these not flowoid areas, these are the areas which are showing no flow. So in the superficial, deep, as well as in choriocapillaries, probably you're looking at retinal choroiditis. And at that same time, if you do an FFA, you might miss those, small satellite lesions. But you do an OCT angio, look at those yellow circles below in the image. You will find that you can clearly see those, satellite lesions. So if this patient is coming to you in a later stages when he is healed, although for a good clinicians and CNVM complex, but if you're in doubt, you tend to do an FFA, but just don't do an FFA, do an OCT angiography and you can see a CNVM complex. Now, as been discussed previously, the OCT angiography cannot show leakage. So how do we diagnose diseases like Behçet's uveitis or any other uveitis? First, OCT angiography is not affected by the leakages, and you can clearly see the CNP areas. And as we have evolved in time, we've understood that the decrease in the vessel density in the superficial as well in deep capillary plexus around the FHS can tell us that the disease is progressing. So if you see that although clinically you can see the disease is not progressing, but if it is there, this means the treatment needs to go on. So OCT with the wide field OCTA, which has been described previously in the previous talk, diseases like IRWAN, which is idiopathic retinal vasculitis, aneurysm retinitis, can be diagnosed by using a wide field OCTA. So another entity which is very common in our countries, which we are endemic to, is trabecular serpiginous choroiditis. So we do understand that we see those yellowish white lesions as the active form, but they do an OCTA. How do you see them on the OCTA? Is those these areas which are circled in the yellow is the flowoid areas with certain hyper reflectivity around it. So when the disease resolves, you see an OCT which shows atrophy. At the same time, visualization of deeper choriocapillaries on the OCTA can help you to understand that probably you're looking at a healed lesion. So although OCTA cannot detect leakage, but it can detect reduced vessel density, suggestive of active vasculitis. Decreased flow in the deeper capillary plexus can be a promising imaging biomarker for disease severity in diseases like bird-shot retinochoroiditis. In granulomatous uveitis, OCTA has a 94.2% agreement with the granuloma seen on ICGA. Flow deficit depiction, especially in the deeper and the chorioretina, may not be a flowoid area, rather a necrotic retina with no detectable flow. Therefore, always correlate the structural OCTs with the NFAS OCT as been discussed before. And the interpretation of the various pathology in uveitis is still evolving. So lastly, OCTA is not an alternative to an ICG or FFA in uveitis, but a respectable adjuvant. As like with any new investigation, OCTA requires standardization, Keep limitation of OCTA in mind while while interpreting the pathologies on OCTA. Thank you.
Thank you so much, Dr. Ankur. Amazing, excellent presentation. As we can see, the next panelist already present here, and in view of shortage of time, we like to close this session. I will thank all the speakers for being here and will request them to please come for a photograph. And our apologies to the next panelists. Due to some AV delays, we were little stretched on time. Thank you so much.